Hello everyone, this is Richard, Acting Senior of A61, and today I will be talking about the exciting topic of the Comprehensive Care Plan that will be commencing on the 14th of April. It's a topic I have thoroughly enjoyed discussing over the last month or two. Thought I would just take the opportunity to talk about it a bit more in depth and hopefully go over some aspects that may have been causing some confusion and maybe streamline some conflicting information you may be hearing. So let's get into it and hopefully it'll all make sense by the end. So the goal of this presentation, we will discuss what it is and why the CCP exists, its benefits, how to complete a CCP, the rules surrounding the CCP, and how it will impact nursing documentation, potentially the most exciting aspects of this brand new shiny tool. So what is it? I am going to put on my very official sounding New South Wales Health voice when I talk about the official description of the CCP. Let's do it. Clinicians used shared decision-making processes to develop person-centered and goal-directed comprehensive care plans that meet identified patient needs, completed in collaboration with the patient, family, and/or carer. This information must be easy for all clinicians to find and action. The new tool is evidence-based, more consistent, accessible, and a practical approach across services with simpler workflows. Yeah, cool. But what did any of that actually mean? So these care plans are designed to act as a reference point to access and understand your patient's care needs. When you take over care of your patient, you can access the CCP and easily find information to learn about your patient without having to cipher through copious amounts of notes. If you've ever come on and had to go through lots of notes and try and figure out what your patient, how they mobilize, what are their care needs, how do they shower, can be quite difficult depending on the consistency of our notes. So hopefully this will address that issue. These care plans should be attended on admission in conjunction with an adult admission and a FRAM, because you need to do those two first to sort of auto-populate some of the CCP. And then they should only be altered if there's a change in the patient's care requirement. So if something changes with the patient clinically, we would commence a new CCP. They do not need to be updated daily. Not like our ad hocs that we do each shift. You do a CCP, nothing changes, it remains there, and we only alter it if something clinically changes. So we'll delve a bit deeper into that as we talk through this presentation. But why? Why do we even need this thing? So the comprehensive care tool, look, essentially this has been designed to meet national standards. Some people who sit on a committee who go through all this type of information and the way we do things have decided this approach will help streamline things. That every patient must have an individual plan that outlines the following things: key risks, goals, their support people, early discharge needs, and follow-up requirements. And essentially, they're just telling us, so we have to roll it out. So let's just deal with it and move forward. Benefits. Are there any? Let's have a look. It should allow easier access to patient care information. Can be updated and accessed by all members of the multidisciplinary team. So eventually all of the allied health teams, medical teams can access the CCP and update any plans that they have related to the patient. If we're using our EMR and iView appropriately and it's to its full potential, it can reduce the documentation requirements that we are currently doing. So if you are entering your cannulas in an iView, please, for the love of God, do that. If you are entering in your fluid statuses on the intake output, you don't need to document fluid status, whatever, or patient eating and drinking, and you don't need to mention bowels, motions if you are updating that in the iView. So again, we're going to sort of like untangle the rules around documentation moving forward. So for this slide, I have shared a video that talks about how to access the CCP and how to actually start it. I'm not going to play the whole video, but I will just play a little bit of it now just to give you a bit of a snapshot of what's in there. Skip
So
forward a
we will leave
bit.
it blank. Next field, there is a symbol of an eye which is called a reference text. So you can right-click on.
So you can just see that was a tiny bit of information. The whole video goes for about 4 minutes, so I would recommend people watch it. I will share this whole presentation, the slideshow itself, via email. So when you get access to this slide, please click on this video. It's a snippet of a longer video, and at the bottom right-hand corner, I have included a link to watch the whole thing as well. So find the time to go over this to help familiarize yourself with the CCP.
To access the comprehensive.
Now let's talk about the comprehensive care plan. Let's break down the whole thing. We're going to talk about each section of it. There's about 7 parts, so let's delve into it. Part 1, Patient Details. So when you open up the CCP, this is what you'll first see. You've got the title up the top there, and then we can see the patient details directly below the title. It talks about their name, date of birth, their age, the ward, their Aboriginal status, all those things. You've got your reason for admission. For this one, it's a fall. The actual diagnosis as well should be implemented on there. And this stuff is auto-populated, so you will not be filling this stuff out. It's actually taken from the patient administration system. I'll be calling that PAS moving forward. And that information is generated when the patient's in the emergency department. And then you don't need to do that, but it does operate as a sort of a good handover tool once you open these up to get a bit of a snapshot information about your patient. So that is part 1 done. We'll move on. Part 2, Reason for Admission. So this section allows more information about the reason for admission to be included in the free text part. So when your patient gets admitted, where it says diabetes needs management review, that'll be blank. You can add more information there if you require. So sometimes our patients come in for one reason, but then it's slowly revealed that they actually got more reasons or more symptoms and more conditions than we first realized. So that this section allows you to add more information on there as well if your patient needs that to give more context to the whole journey. Okay, this is like a Tarantino movie. Part 3, Partners in Care. So a patient's status as a carer, or if they require a carer, can be automatically extracted from the PAS. The care information section on the left is not editable. If the care information from the PAS is incorrect, it can be updated. You just need to talk to our ward clerk to attend that. The notes section on the right allows staff to include details that are important to the patient, their carer, and family. So if this particular patient has carers that come in a particular time, you could write that. If there's a son or a daughter or a family member that don't want information to be handed out to, you could write that in there. If there's nothing that needs to be written in that particular section, then you don't have to write anything in there as well. Part 4, Introduction, which sounds like it should be part 1, but hey, let's just deal with it the best we can. So in part 4 in the introduction, this section provides a quick overview of the patient regarding safety and other important physical, emotional, mental health aspects. Some of our patients, look, they might have particular things that they like to be known about them to help assist with their care, and this section just allows us to fill that in there. Some of the types of information that could be included in this brief overview are displayed on the right and the image below. Part 5, Fundamentals of Care. Okay, this is probably the longest section of the CCP and probably the most helpful part as well. So on the left, all those 1, 2, 3, 4, 5, 6 columns, if you have done your adult admission assessment and your FRAMP, some of that information is dragged across into here and is auto-populated. So now on the left, on the right, I'm sorry, those columns when they first arrive will be yellow, and those are our mandatory fields that we need to fill in. And it also allows us the opportunity to provide more context in terms of care for our patients. So the section that is auto-generated, for example, by the FRAMP, so if they're of a high falls risk, then you can move across to the right and then write your strategies. Have you implemented a falls alarm? Do we need a one-to-one special? Or if they're identified as a high pressure area risk, have we implemented an air mattress? So those are the sort of things that don't change too often in terms of our patient's journey. So once it's done, we leave it. You don't need to keep writing your notes that the air mattress is in place or that the falls alarm is in place. It's in there, and if it hasn't changed, then you don't need to keep documenting. So take the time to look through those sections and then looking on the sections on the right and the term and think about what you could put in there to prevent you writing long notes day to day. Part 6, Goals of Care. So this section refers to the outcomes the patient wishes to work towards during their hospital visit, which I would imagine would be them trying to get home. The care team, which is us and the patient, collaboratively determine these goals to ensure they are clinically appropriate. Can you tell I'm reading from a script? I hope not. They encompass the midterm goals the patient wishes to achieve during the admission, those they wish/need to achieve to be ready for discharge, and the goals the patient will work towards at home or in transitional care. These are likely to be revised during the encounter and can be updated whenever the patient wishes. So when your patient first arrives, you might ask, hey, what are your goals in this admission? And they're going to look at you and say, to get out of here. So you could, patient wishes to be independent and return home. And then on the right, we could be writing, what do we need to do to achieve that? Ordering a physio, ordering an OT assessment, or if they're trying to become more independent or goals with weight loss or anything like that, you could document that there on the left, and on the right, what are we trying to do to achieve those goals for the patient? The final part, part 7, plan. Alrighty, this final section of the comprehensive care plan is where the multidisciplinary team document their review of the care plan. Initially, when a patient is admitted, the nurses can populate the plan. So just think about when you usually get your patients to come up from ED or another ward, there will be a plan from the medical team or the emergency doctor, hopefully. And then you can use your clinical judgment about what needs to go into the plan. What is the stuff that needs to be achieved for our patient in terms of their medical care to make sure that we are handing that over to do what we need to do to get them discharged. So for example, if we got a patient with exacerbation of COPD, the plan may be maintain SATs 88 to 92, continue puffers, commence prednisone, await team review in the morning. That could be your plan when they initially present to the ward. Then when the team see the patient and things alter, then you would start a new CCP and then edit the plan. So this is not a section for us to put our nursing things in, like bowels open today, pressure area care attended, crash mat in place. It's a place that's meant to be used to communicate the medical interventions that affect how this patient will get home. So you could be writing stuff like await PET scan on the 11th of the 4th or continue IV antibiotics until ID review. I hope that section makes sense. CCP requirements. Like anything or any tool in this profession or this industry, there are some requirements around it. All ward inpatients will need a CCP from the 14th of this month. Patients in ICU do not need a CCP due to ERG use, so they're the only unit that's excluded from this. CCP needs to be started within 8 hours of a ward transfer, but remember, you also need to attend your adult admission assessment and your FRAMP to help auto-populate some of the information in there. A new entry must be created to update a CCP whenever there is a change in clinical condition, change in patient's plan of care, a case conference plan update. If there is no clinical change to a patient, it does not need to be attended every shift. I'm going to use an example of a patient in A61 who's currently awaiting a nursing home that can facilitate his peritoneal dialysis needs. This patient has been on our ward for over 100 days. His plan has not changed. We wash him the same, we're feeding him the same, we're transferring him the same. So if you attend a CCP, all that information does not need to be documented on a shift by shift basis. It's there, and we would only alter the CCP if something changed. Okay, so I hope all of that made sense regarding the CCP, and now we're going to discuss documentation. So just some things about documentation. One of the benefits, hopefully, of the CCP will be reduce the number of items that we need to document on a daily basis. There is no longer a need to write an A to G assessment each shift. However, as per protocol, a note must be made each nursing shift. If you are documenting information in the EMR, such as access devices, your observations, or bowel movements, then you don't need to write a note about it. So that please be gone the days of us writing OBS stable. I don't need to see that if you've already entered the OBS into the EMR or medications given as charted. I can see who gives the meds, you don't need to chart it. If you've charted bowels open in the iView and the stool chart on there, then you don't need to write bowels open as well. So essentially think about if the information's somewhere else on EMR during your shift, then you don't need to document it. We're trying to remove all those double documentation aspects that have crept into this profession. So then what do I write? Let's explore that. Essentially, you write what cannot be entered into either the CCP or EMR. You write contemporaneously. So I hope I pronounced that word correctly. Think about how the nurses in ED write their notes. They write a note when they take over care. If they have to start a blood transfusion, they'll write blood transfusion commence and then da 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 da. If they've had to send an MSU, they would write that as well. They're kind of writing in real time. That's how we kind of need to approach our notes moving forward. That gives us a better idea of the care that's being provided to our patient. Our long A to G notes often don't tell us a lot when I have to investigate an IMS or other situations. They're quite generic and they're kind of pointless some of the time. So our goal is to improve the quality of our information in the notes, not the quantity. You follow the philosophy of the four whats. What happened? What did you do about it? What was the outcome? And what is next? Do we need to update any risk assessments or water load? Let's use the example of you found a patient with a pressure injury. Then you'd be writing what you found, what you did about it. I notified the team, or did a water load, ordered an air mattress, got a wound care referral, blah, blah, blah. What was the outcome? Awaiting assessment. What is next? Then we'd update the water load and update the CCP as well. So try and think of that as your philosophy moving forward when you're doing your documentation. But Richard, what would my note actually look like? Okay, I'm here to help you guide you through that query. So right now, I've just taken a screenshot of someone's A to G notes here in A61. If you recognize this as yours, please don't feel like I'm picking on you. I just picked one at random. You can see it's quite a lot. It's quite long. And if you've got 4, 5, 6 patients and you're writing this on a shift by shift basis, that can be the anchor that drags you down of getting out of here on time. So our goal is to go from notes that currently look like this to looking like this. Took over care at 7:15, ID band checked, correct, emergency equipment checked, call bell within reach, hourly rounded attended, care provided. And for this particular example, I just pretended someone was stable, but then just try to throw in a caveat about some information that you couldn't enter in the CCP or EMR. Patient refused to sit out of bed. Despite encouragement, author will reattempt after lunch. Noted this AM shift, bowels not open for 3 days, request my blah, blah. Anyway, you can read it all. And the plan is going to be as per CCP. So the CCP needs to be acknowledged each note. I should mention that. So I look forward to reading people's plans moving forward. Instead of reading as per team, now it was saying as per CCP. Bit more info about documentation. If you believe something needs to be charted to either protect yourself or provide more context about the patient's care, then chart it. What we are aiming to do is remove the unnecessary aspects of the nursing documentation that have crept into our practice. Again, focus on the quality, not the quantity of what you write. You should be documenting any changes or interventions for your patient as they occur. We still work in an acute setting here, so as things occur, we should be documenting and providing context for the care for our patient. For example, if your patient has received a blood transfusion during your shift, you could document the following. So I'm not going to go through the whole thing, but just I will pause for dramatic effect for 2 seconds whilst you read all that. So hopefully you've read all that, and hopefully that gives a bit more context or understanding about our documentation moving forward. So in summary, let's wrap this baby up. The CCP is a tool made with patients, families, and carers to highlight a patient's care needs and their goals. It will allow a more streamlined approach to accessing certain patient information. All patients require one on admission in conjunction with an adult admission assessment and a FRAMP. It does not need to be done daily if there is no clinical change. Nursing documentation will be altered as a result of the CCP. Team, if you have any questions, please reach out to me so we'll help navigate this as we move forward. I do anticipate some issues and maybe some transitional shock as we go forward. Essentially, we are telling nursing staff to not listen to decades of document, and now moving towards a new system. I guess the essential message I want to leave you is focus on the quality of your notes, not the quantity. Do the CCPs as best you can, and as the rollout continues, I will be there to guide you through it. So let's work together, we'll figure it out, and hopefully the next presentation I do will be something a bit more stimulating to the mind. Thank you very much.